3, consider a second opinion. Choosing a surgeon is among the most important things that you and your patient will do when she's diagnosed with breast cancer. You could take this approach, which is to say that your surgeon can take this approach, which is to say that I said your gallbladder, but if you insist on a second opinion, I'll see your kidney. The issue is that if a surgeon discourages your patient from getting a second opinion, he or she does not have her best interest in mind. So they need to be able to be willing to stand by their recommendation and give the patient the opportunities to have other views of how they can be managed. So what does a second opinion provide to your patient? Well, it might affect the recommendations regarding her option for lumpectomy. It might affect her options for mastectomy or reconstruction, whether or not it's offered, whether or not it's offered as an immediate or delayed procedure. It might affect the option for participation in clinical trials, particularly those trials that are performed at the time of surgery or prior to surgery. It can affect the surgical outcome, of course. It might end up requiring surgery and multiple procedures as opposed to one procedure. And it also can affect their patient, the outlook, their entire emotional relationship with their cancer and the cancer treatment experience. Number 4, insist on a core needle biopsy. Now, the slide I showed you before, this 15 to 60% incidence of positive margin rate, a lot of these patients had positive margins because the surgeon did not obtain a preoperative diagnosis of cancer. They were taken to surgery for an excisional biopsy which yielded cancer that had a positive margin that required additional surgery. So knowing that it's a cancer prior to taking the patient to the operating room improves the chances that the mass would be removed with widely clear margins. And that's why performing needle biopsy is important. It also gives the patient the opportunity to consider other things that she might desire to have done, like mastectomy with breast reconstruction, for example, or lymph node staging. So doing the core biopsy before surgery is really important for those reasons. We want to discourage patients from having diagnostic excisional biopsies where they're taken to surgery to have the diagnosis made, although it is emotionally comforting to some people to get it out first and then deal with it. It's really the wrong first step because they can burn many bridges that they can't cross again because they made that step. So we want to avoid things where we take out a tumor with an excisional biopsy, leaving behind positive margins because we didn't really anticipate the full extent or the fact that this was cancer. Or in a mass like this where we took it out kind of just to remove it for patient comfort, but to find out that it was a cancer that was inadequately removed. In both cases, this problem could have been avoided by obtaining the preoperative diagnosis of cancer. So if a mass is ultrasound visible, the preferred procedure is to perform an ultrasound guided core biopsy. You're able to do a real-time sampling of the tumor, get an adequate specimen so that you can get an accurate diagnosis, and then recommend treatments based upon that. If it's not visible by ultrasound but visible by mammography, such as microcalcifications, then we do stereotactic core biopsy with the same goal of removing the sample, getting a diagnosis, counseling the patient, and then going to surgery with the intent of being there only once to solve her problem. We would rather preserve surgery, therefore, for treatment of cancers, for removal of high-risk lesions, for removal of discordant results that are not adequately resolved by a core biopsy, and for removal of symptomatic benign lesions that bother a patient, so we take them out for that reason. Let's go on to number 5. Ask the surgeon to obtain wide margins. When it comes to margins, less is not more. The problem is that we rely upon removal of the tumor based upon the extent of what we can see. We do mammogram, ultrasound, perhaps MRI, we map the extent of the lesion, and then we remove it. But the microscopic size of a tumor is often different than what we see by imaging. So we have to remove the tumor with a wider margin to have a little room for insurance that will get around it and not leave tumor at the edge. So we want to avoid a situation where we have a positive margin where the tumor comes all the way to the edge, and instead take a more generous margin so that we'll at least have some room between the tumor, which is shown here, and the cut margin here. That's the goal, and that's the benefit of planning on taking wider margins. You'll have more cases like this and fewer cases like that. We facilitate removal of wider margins by using multiple bracketing wires. I described that earlier. We place these wires, or the radiologists place these wires into the breast prior to surgery. We place 1, 2, sometimes more to the left, right, or in the perimeter of the tumor so that when we take it out, there's a rim of normal tissue around the tumor and improves the chances that the initial operation will be successful. Another example of it is here. Here's a tumor in this position. There's a clear margin grossly, in these directions that was facilitated by placing multiple wires. Again, we want to avoid a situation here where we use only one wire, particularly for larger tumors, because had we placed a wire over here, we might have had a better chance of getting around these calcifications over there with a clear margin. In this case, it was not accomplished because only one wire was removed. So my practice and the practice of most surgeons in this institution is to use multiple wires when appropriate. And we also supplement the use of wires with ultrasound for ultrasound visible tumors. The image here is off the slide, but the point is that the ultrasound gives you another handle on visualizing the tumor, on visualizing the gross margins, and so you can plan the resection with the use of ultrasound because it has a potential to improve the margin resection.